Hi, everyone. Welcome. Thank you so much for being here. We'll wait just another moment so that everyone can be admitted from the waiting room, and then we'll get started. Excellent. Good afternoon, and welcome to the IMSMP and Tisch MS Research Center of New York's Quarterly Connect webinar series. I'm so glad that you've joined us for a conversation on special topics in MS, featuring treatment optimization, a discussion of BTK inhibitors, and women's hormonal considerations as it pertains to MS. For those who don't know, Tisch MSRCNY is an independent nonprofit research center dedicated to finding the cause of and cure for multiple sclerosis. We're located in the heart of New York City, where we conduct industry-leading medical research in collaboration with the International Multiple Sclerosis Management Practice, a world-renowned treatment hub. Together, Tisch MSRCNY and IMSMP make up the world's largest independent MS center. We're really committed to expanding the scientific understanding of MS and redefining patient education and involvement in research, which is why we offer webinars like these, because we want you to know what's going on behind the scenes. I'm Sarah Bond, and I lead communications for the center. I'm joined today by three attending neurologists from IMSMP, Doctors Williams, Stark, and Mohadri. If you have a question during the session, we ask that you please hold them till the end. You can add them to the Q&A box at the bottom of your screen, and we'll answer them after all three discussions. As a quick reminder, we can't answer any personalized medical questions during public webinars, and if you have an individual question, you're more than welcome to call our office. We will hear from Dr. Williams first. Dr. Williams completed medical school and his internship at University of Virginia Medical Center. He trained in neurology at the Neurological Institute of New York at Columbia University Medical Center, served a 2-year neuroimmunology fellowship with Dr. Saud Sadiq, and joined IMSMP in 2007. Dr. Williams, the quest for optimization is increasingly part of the conversation in health spaces. If a patient wants to optimize their MS treatment, we're hoping you can share a little bit about what that looks like.
Yes, I'd be happy to answer the question, and good afternoon, everyone. In my talk, I want to give you an overview of how to optimize therapy, starting with where we were in the past, so that you can understand stories from the past about what MS was have radically changed. And to be able to understand how to optimize your own care, you need to understand the history of MS and how we made opportunities in the disease. If you could go to the next slide, please. Sarah, if you could go there, thanks. So the history of MS was, when I started, doctors at my own institution, when I chose to go into MS, they were pretty nihilistic. They basically said, don't go into this area of neurology. You and your patients are going to suffer. And I thought that was awful advice, because I could see some doctors were approaching it with optimism, especially Dr. Sadiq. I could see he was making headway and that he was seeing opportunity. But here's what things were like 20 years ago. It's important to understand the diagnosis of MS was made far later, when people had had multiple relapses and doctors could be sure it really was the disease. And when people were diagnosed and they would have a relapse or a new MRI lesion, this was accepted. The therapies that were out, the interferons and glatiramer, otherwise known as drugs like Avonex and betaseron and Copaxone, they were modestly effective. And doctors thought that was the best we could achieve, and that's all there was. So that the goals at the time were fewer relapses or milder relapses. Hopefully someone wouldn't go into the hospital with a relapse, but if they had a relapse, but it wasn't so bad, that was considered good. And when someone had a relapse, the doctor's response to this, a standard response was to give steroids, either continue the same medication or move to another medication in the same category, moving from Avonex to beta seron, because beta seron is more interferon. And doctors also, and even the scientists, had developed what they thought was a scientific model in which disability was inevitable. And that's all changed. And as you look on the right side, each one of these pieces has played a part in creating opportunity for MS. We're making the diagnosis of MS earlier. We're using highly effective therapies earlier. If we don't accept relapses in new MRI lesions, we want to prevent them, but if we see them, we'll escalate therapies or switch to a different mechanism of therapy. And our goal is no evidence of disease activity, no MRI or clinical activity. So that our current goals, versus seeing disability as inevitable, our goals are to prevent MS activity and disability. And we don't see progression as inevitable. If you go to the next slide, please. So what's changed, if you look at the paradox of MS, or one of the paradoxes, is that there's a large separation between the time when someone has relapses into MRI activity and much later people tend to develop disability. So it could be interpreted as maybe these are separate processes, or maybe the inflammation doesn't have anything to do with the eventual apparent functional losses in the nervous system. And so the paradox is that this inflammation occurs early, the disability can occur some through relapses, but much disability occurs slowly, years after the relapses. And what's changed in our thinking is that whereas we used to think there was no connection or limited connection between the inflammation and disability, now we believe and we understand that inflammation causes damage long before the disability becomes obvious. The nervous system can handle small injuries, can repair from them. But if we allow those to accrue, the body loses its ability to repair, but also the immune system shifts as it continues and it smolders along. So it's better to turn that off early. So what's changed in our actions are that we make the diagnosis of MS much earlier. The whole criteria for how to know that someone has MS by using MRIs or spinal fluid, as well as the exam and history, allow us to make a clear diagnosis and confident diagnosis of the disease early, and then start treatment early. And we look at inflammatory MS activity as unacceptable. We see it as an opportunity to do better. And with this, our results have changed. It's rare in any month, it's rare for me to see someone with a relapse or a new MRI lesion. And the patients that we've treated to a standard of seeing no evidence of disease activity, when we've treated people from disease onset, very few of them are going on to develop disability. Next slide, please. I'm going to talk about I'll give you some names of highly effective therapies, but understand the background concept that these drugs can dramatically reduce inflammation for a group of people with MS. So the highly effective therapies include the B-cell therapies, Ocrevus, otherwise known as ocrelizumab, Kesimpta, or ofatumumab, and Briumvi, ublituximab, as well as drugs including Tysabri, Mavenclad, and Lemtrada. These drugs are highly effective for treating patients on a group level. And so they set the standard. When we started seeing patients would stop having new MRI lesions and they would stop having relapses, all of a sudden our goalposts changed. It's important to understand, though, other platform therapies and even what we call moderately effective therapies may help you as an individual achieve perfect results as far as we can tell. So these drugs set the standard. You don't have to be on one of them necessarily to be achieving those results. But if you're not achieving those results, you would look to this group of medicines. Next slide, please. Sarah, if you could advance the slide. So as I've said, our new goal is no evidence of disease activity, or NEDA. We want to see no relapses, no new MRI lesions, and we take a careful look for no evidence of disease disability progression. So we'll take a careful history. What are you doing at home? What activities are you engaging in? Are you engaging in new activities? Sports, are you starting to limit what you do? And we add to that our exam and a cognitive evaluation. Instead of accepting a disease activity, we prevent it. Certainly, if we're not seeing someone achieve this goal of NEDA, we look to do better. We ask on a scientific level, looking at all the tests and a careful history, how can we do better? Next slide, please. Treatment for MS is more than medication, and this works on a biological level as well as your quality of life. Most important, but as a great example, smoking is an aggravant for MS. It increases the risk of developing MS as well as the risk of progressive MS. And this is seen in other autoimmune diseases as well, and it's also seen for cardiovascular disease. On the flip side, if you stop smoking, it actually mitigates your risk of progressing. So that is, controlling risk factors actually can help your brain and the MS. So in addition to not smoking, maintaining exercise. If you aren't exercising, do something with joy. Maintain a healthy weight and get a good night's sleep, and manage your cardiovascular risk factors such as hypertension and diabetes. Next slide, please. So I'm giving you just the overview. I'm not telling you what drug to take, but I am trying to impress upon you things have radically changed. And we've seen it. We're seeing it in practice. So many of my patients do well nowadays, whereas I remember a lot of patients having a hard time 20 years ago. 20 years ago, many newly diagnosed patients face expectations of relapse, disability, loss of work, being a burden to their partner or their family. That's changed. Today, if people are diagnosed and treated early, many of them, most of them, I'd say, with relapsing remitting MS certainly, can expect highly functional lives. It's still a serious disease, but you can treat it and you can get a great result, and you should be seeking opportunity. Yes, the therapies have some risks of side effects. You can discuss those with your doctor, but over time, we've worked to find great treatment protocols to prevent side effects for most of our patients. And most of the side effects that do come up are quite manageable. It's nothing like the experience of someone who's receiving therapy for cancer or an organ transplant. And today, the outlook continues to be optimistic. There's more to learn, even as we've created success. Next slide, please. So when I'm thinking about what's next, there's still room for improvement. Beyond the MRIs, I expect us to, and people are working on better markers to optimize treatment. We're not there yet, but I expect it will come soon. And we hold out hope that there are more opportunities to repair the existing damage. I'm not sure how that'll be done, but I would say it stands to reason. There are ways to support the body's natural mechanisms of repair. And I hope that we will make more headway with progressive MS uh, in the same way when we thought relapsing remitting MS was hopeless or couldn't be treated, we're frustrated by the modest benefits we've had for primary progressive MS. I, I expect we need a paradigm shift, but I expect we'll be able to treat that as well. And I am very hopeful that one day we'll be able to restore lost function if the body will permit. Thank you very much. At the end, I'll take questions.
Thank you so much, Dr. Williams. We are now going to shift gears a bit. It was really helpful to learn about the philosophy behind those treatment decisions. But of course, those perspectives evolve as new pharmacological products come on the market. And Dr. Stark is going to discuss the biggest class of drugs emerging, BTK inhibitors. Dr. Stark completed medical school and his neurology residency at Albert Einstein College of Medicine in New York, where he served as chief resident. He completed a neuroimmunology residency with Dr. Sadiq, and in 2019 was elected a fellow of the American Academy of Neurology. Dr. Stark, to get us started, maybe you can just give us a little overview of what actually is a BTK inhibitor.
Thanks, Sarah, and good afternoon, everyone. I wanted to talk about BTK inhibitors today, and that's Bruton's tyrosine kinase inhibitors, because they are an entirely new class of drugs that we've been following for years now. And there have been some recent developments that have even made the news. One problem we've had with recent MS drug development is that all of the recent approvals have really just been new versions of old drugs. So, Kesimpta, Briumvi, Mayzent, Ponvory, Zeposia, Vumerity, they all work in the same way as drugs that we've already had. There are just slight differences in testing requirements or how they're given. The last new drug with a truly new mechanism of action that was approved was Mavenclad in 2019. And even that drug was available for years as a chemotherapy for certain types of cancers. And although there are a few truly new drugs in development, nothing has caught on like the BTK inhibitors. Because every pharmaceutical company wants one, there are 5 that have been studied. And although there are some significant differences between them, they all have the same mechanism of action. So here you see the names of them in front of you, just so you can really see the names. We have evobrutinib, tolebrutinib, fenebrutinib, oralibrutinib, and remibrutinib. The ending brutinib is what's common to all the BTKIs. Next slide. So to summarize the BTK inhibitors, well, they're all oral pills, and the active ingredient is a very small molecule, which can penetrate the blood-brain barrier. So it gets into the brain and spinal cord, which will become important in a minute. The mechanism of action, well, it works on a number of different cells, but the one that's sort of most exciting is the effect on microglia. And microglia are sort of the cleanup cells of the central nervous system, and we've never been able to target them before. But they also do work on B cells, and we know how well inhibiting B cells works in relapsed remitting MS. Previs, Kesimpta, and Briumvi are the biggest class of drugs in MS right now. And it also works on other cells like dendritic cells, macrophages, mast cells. And the only reason I bring all of this up is because, like most things with the immune system, it's not completely clear-cut how it works. There was a generation of these drugs before the current ones that I'm talking about, and they had some safety issues, including bleeding problems. Those have been resolved in the second generation, but this entire category group generation has been associated with liver toxicity, and that will also become important a little bit later. But one advantage is that they don't really immunosuppress patients the way that some of our other drugs do. So that's certainly one advantage to this group. They're also being studied in other autoimmune conditions like lupus, rheumatoid arthritis, and chronic spontaneous urticaria, which is an autoimmune skin condition. Before we get into the studies, I'll start that we had early hopes for BTKIs to treat progressive forms of MS because they make their way into the brain through the blood-brain barrier. And we think what's causing the problems in progressive MS is already inside the brain and the spinal cord. Plus, the mechanism of microglial inhibition is very interesting, and there's been a lot of laboratory data that microglia are important in progressive forms of MS. And again, we have not been able to target that cell type before. So now let's get to the trial data. First of all, phase 1 trials, just look at a few patients, mainly for safety evaluations. Phase 2 are small trials of about 50 or so patients, and they're basically just to justify doing 2 expensive and lengthy phase 3 trials, which is what is required for FDA approval. Evobrutinib, tolebrutinib, phenibrutinib, and orelabrutinib all did short phase 2 trials. And interestingly, none of them had significantly positive clinical endpoints in any of those trials. They all showed benefit in MRI changes and only in relapsing remitting multiple sclerosis. Remibrutinib completely skipped phase 2 altogether to try to get a head start on their phase 3 trial. So I'm not going to get bogged down in the details of the phase 3 trials, but evobrutinib, tolebrutinib, and phenibrutinib have completed 2 large phase 3 studies in various forms of MS. So let's start with evobrutinib. Evobrutinib was tested in over 2,000 relapsing remitting patients and compared to Aubagio, or teriflunomide. In the trial, evobrutinib worked, but neither trial showed that there was any difference in relapse rate, disability progression, or any of the MRI endpoints between the 2 groups. So the drug was not approved because it was not better than something that we already had that was arguably one of our weaker drugs. And of course, there were the issues with liver safety, which we'll get to later. There are no further studies using evobrutinib at this time. Tolebrutinib was tested in almost 2,000 relapsed remitting patients and also compared to Aubagio. And again, neither trial showed a difference in relapse rate, disability progression, or new MRI lesions between the 2 groups. So again, it wasn't approved for relapsed remitting MS. The next development was that tolebrutinib was studied in non-relapsing secondary progressive MS, which is a subtype of MS for which there are no currently FDA-approved treatments. So this was an important study. It was actually published in the New England Journal of Medicine, and this is the one that made the news. The percentage of participants whose disability got worse in this trial was 22.6% in the tolebrutinib group and 30.7% in the placebo group, which is a difference of about 8%. Now, that was statistically significant, but clearly a very small absolute difference. And when they study the upper extremity function in these patients using the 9-hole peg test, or the lower extremity function in these patients, seeing how fast they could walk 25 feet, there were no significant differences between the groups. So the overall disability score was slightly worse in the placebo group, but they couldn't show that when specifically looking at arm or leg function. But here's where there was a big problem with the liver safety. So more patients in the tolebrutinib group had liver testing abnormalities, and one patient required a liver transplant and died of complications. So when weekly liver function monitoring was started, patients showing liver toxicity stopped treatments at the first sign of a problem, and all those abnormal cases resolved. And that's what made us think that if the FDA approved it, they would require weekly liver monitoring for the first few months if that drug was approved. However, around 6 months ago, the FDA flat out rejected the application because they said that when they looked at subgroups within the study, they felt that the 8% benefit of the drug was all in those patients who had MRI changes during the study. Now, the study was supposed to be in non-active patients, so those who weren't having attacks anymore, or MRI changes. But of course, MRI changes can happen at any point in MS. So the FDA said that the patients that were getting benefit were not actually the non-active SPMS patients that this trial was trying to target. The next development in the saga was that the EU, the European Union, actually approved this drug in April of 2026. So it should be available there relatively soon. But I'm not really sure why, based on the data. We know we all have the same data, and the FDA showed that pretty clearly in their review a few months ago. There is also a tolebrutinib versus placebo study in primary progressive MS, and that study has been completed, but we don't have the data for that yet. Finally, fenebrutinib, which for various reasons has been thought to be the strongest BTKI, issued a press release a few months ago. So I have not seen any of the actual data. This is all from the company that makes the drug. But the press release said that in relapsing remitting MS, fenebrutinib performed better than Aubagio, which is the first BTKI to ever actually show that. The same press release also claimed that fenebrutinib did just as well as Ocrevus in primary progressive MS. And Ocrevus is the only medication currently approved to treat PPMS. We are waiting for these studies to be published, which should happen very soon. So we'll see what the safety looked like in these studies, although there was still some liver toxicity with monitoring every other week. Right now, there are no further studies using fenebrutinib, but if this data is accurate, then I would be very interested in a study that combined fenebrutinib with ocrelizumab in primary progressive MS. As for the future, orelabrutinib phase 3 PPMS and SPMS trials are currently recruiting. Remibrutinib has a phase 3 relapsing remitting trial planned, and an ocrelizumab switch study, meaning they were taking people on ocrelizumab in relapsing remitting MS and transferring them to remibrutinib after a period of time. They are also planning a secondary progressive MS study. And that's where we are with the BTK saga. I am hopeful for more data in progressive forms of MS. And as I said, there are a few new classes of drugs also being investigated in all forms of MS, but that will be discussion for another time. So what can you, the patient, take from this? Well, you can talk to your doctor about whether BTKIs may be right for you, but this can really wait till your office visit. Even after approval, these medications will take months before they're fully available on the market. But how do I think I'm going to be using these drugs? Well, in relapsing remitting MS, I don't see a role for them in relapsing remitting MS, given that they are less effective, less convenient, and they have these liver safety issues than the drugs that we already have. The only benefit is that it could be less immunosuppressive, although that has not been a frequent issue with our current high efficacy treatments. But maybe in certain high risk groups or in our very elderly patients who might be at more risk for vulnerable to immunosuppression, that may be useful in those populations. In primary progressive MS, I would certainly do Ocrevus first, and I would use fenebrutinib in my PPMS patients who are clearly worsening Ocrevus. But I would actually love to see again what a combination of those drugs would possibly do. Fenebrutinib and Ocrevus. SPMS, I don't really have an answer for that right now. I would wait till it's out in the market for a little while longer to get more experience with it. All right, that's it for now. Thanks everyone for taking the time to listen.
Thank you so much, Dr. Stark. MS is definitely a nuanced disease that affects everyone differently based on dozens of factors. And for women or any individual with ovarian function, managing it is further compounded by monthly hormonal cycles and broader hormonal transitions, including reproductive years, perimenopause, and menopause. And to speak a little bit more about that, we'll turn to Dr. Mahadri. Dr. Mahadri completed her medical education in Iran before moving to the US to pursue advanced training in neurology. She completed her internship at Rutgers University and neurology residency at the Hackensack University Medical Center's JFK Neuroscience Institute, where she served as chief resident. Her neuroimmunology fellowship was also at Tisch MS Research Center of New York under the supervision of Dr. Sadiq, and she joined the attending team at IMSMP in 2024. Dr. Mahadri, can you start by giving us an overview of MS considerations at these different stages of life?
Sure. Thanks, Sarah, for your introduction, and hello, everyone. So when we look at MS, we know it doesn't affect everyone the same way. MS affects women roughly 3 times more often than men. Women's health isn't just a side topic. It is at the very heart of how we understand and manage this condition. I'm sorry. Throughout a woman's life, her body goes through incredible transitions, from monthly cycles to possibly pregnancy and eventually into menopause. Each of these phases involves major hormonal shifts and that can interact with MS in unique ways. Today, we will discuss some of the most important milestones in a woman's life and explore how they interact with multiple sclerosis. As you all know, MS is an immune-mediated disease, and the immune system does not function independently of body's hormonal environment. Hormones such as estrogen and progesterone influence many aspects of immune regulation, inflammation, and even communication within the nervous system. Because hormone levels naturally fluctuate throughout a woman's life, it is not surprising that many women notice changes in their MS symptoms during certain hormonal transitions. One of the most common examples is the menstrual cycle. Many women with MS report that symptoms such as fatigue, cognition fog, numbness, pain, imbalance, or even weakness become more noticeable in the days leading up to their periods. This phenomenon is common enough that it has been studied in clinical research. And while the underlying factors are not completely understood, hormonal fluctuations are believed to play an important role. These temporary symptom fluctuations are not relapses. A true relapse represents new inflammatory activity within the central nervous system and typically lasts for at least 24 hours in the absence of infection or another explanation. These hormonal changes may temporarily amplify existing symptoms without causing new damage or new disease activity. Basically, hormonal changes can temporarily lower the nervous system's ability to compensate for areas that have been previously affected by MS, making old symptoms more noticeable. Hormones also influence factors such as sleep quality, body temperature, mood, energy level, and pain perception. And as many of you know, these factors can significantly impact how MS feels on any given day. Understanding this relationship is important because it helps us recognize that not every symptom change means the disease is worsening. Sometimes what we are experiencing is the interaction between MS and the hormonal, that basically normal hormonal transitions that occur throughout a woman's life. One of the most remarkable examples of the relationship between hormones and MS occurs during pregnancy, when the body undergoes profound hormonal and immunological changes. One of the questions I often hear from women after a MS diagnosis is, can I still have children? The answer for the vast majority of women is absolutely yes. One of the most encouraging things that we have learned in women with MS is generally that they have normal fertility and can expect healthy pregnancies and healthy babies. Large studies showed that MS does not significantly increase the risk of miscarriage, birth defects, stillbirth, or most pregnancy complications. Basically, MS itself is not considered a high-risk pregnancy condition. During pregnancy, the mother's immune system must adapt to tolerate a fetus that is genetically different from her. Rather than simply suppressing the immune system, pregnancy creates a state of immune tolerance. This shift helps prevent the maternal immune system from attacking the developing baby, but it also has important effect on autoimmune diseases such as MS. As pregnancy progresses, especially during the second and third trimesters, levels of estrogen and progesterone and other pregnancy-related hormones rise dramatically, and these hormonal and immunological changes are associated with a reduction in inflammatory disease activity. Historically, studies have shown that the relapse rate declined throughout pregnancy, reaching their lowest point during the third trimester. This observation has been one of the most striking examples of how hormones and the immune system interact in MS. However, it is important to recognize that pregnancy is not a cure for MS. Some women may still experience relapses during pregnancy, particularly those with highly active disease before conception or those who stop certain disease-modifying therapies. This is why careful pregnancy planning and close coordination with your MS specialist are so important. Pregnancy is not harmful to MS, and MS is not a reason to avoid pregnancy. With appropriate planning and individualized treatment decisions, most women with MS can expect healthy pregnancies while maintaining excellent control of their disease. Before I move on from pregnancy, I want to briefly touch on fertility treatments because this is an area where our understanding has changed significantly over the past decade. Assisted reproductive technologies, or ART, including treatments such as IVF, account for approximately 2% of live births in the United States. Just like women without MS, some women with MS may require fertility treatment to achieve pregnancy. MS itself does not appear to impair fertility, and the need for fertility treatment is not higher among women with MS compared with the general population. Historically, there was concern that fertility treatments might increase relapse in MS. However, more recent studies have been reassuring, showing no significant increase in disease activity. This likely reflects improvement in fertility protocols and better disease control throughout the conception process, including appropriate use of disease-modifying therapies. So the key takeaway is that fertility treatment is not contraindicated in MS, and close coordination between the fertility and MS teams can help optimize both pregnancy outcomes and disease control. Now I want to move on to postpartum period, which is a completely different period. As I mentioned earlier, during pregnancy, the immune system exists in a state of relative immune tolerance to support the developing fetus. After delivery, that state rapidly reverses. So hormone levels, particularly estrogen and progesterone, decline dramatically, and the immune system gradually returns to its pre-pregnancy state. As a result, the protective effect of pregnancy is lost and the risk of inflammatory disease activity increases. Historically, studies have shown that relapse rate rises during the first 3 to 6 months after delivery. More recently, MRI studies have shown that postpartum disease activity may be even more common than what we recognize clinically, meaning that there are new MRI lesions without having clinical symptoms. However, postpartum disease activity is not inevitable. Good disease control before conception and a clear postpartum treatment plan and a timely resumption of therapy are all associated with a lower risk of disease reactivation. This is why I encourage patients to develop a postpartum plan before delivery, including follow-up visit, MRI, breastfeeding goals, and treatment decisions. While the postpartum period is an exciting time, it also brings significant physical, hormonal, and emotional changes, and planning ahead allows us to focus on protecting the mother's long-term neurological health. Breastfeeding. Breastfeeding is a deeply personal decision, and there is no single right choice for every woman with MS. One of the questions researchers have asked is whether breastfeeding itself influences MS disease activity. Several studies have suggested that breastfeeding may be associated with a lower risk of postpartum relapses, with some studies showing up to 40% reduction in relapse rates. However, interpreting these findings can be challenging because women who choose to breastfeed often have less active disease to begin with. Therefore, while breastfeeding may provide some protective effect, it should not be viewed as a substitute for appropriate disease-modifying therapy. A key area of progression has been our evolving understanding of medication safety during breastfeeding. Historically, patients were often advised to choose between breastfeeding and resuming disease-modifying therapy. This approach has completely shifted. We now know that many monoclonal antibody therapies transfer into breast milk in extremely small amounts. And due to their large protein structure, they're poorly absorbed in the infant GI tract, resulting in negligible systemic exposure. So as a result, many patients can safely breastfeed while continuing highly effective MS therapies. Ultimately, the goal is not to tell women whether they should or should not breastfeed. Rather, the goal is to help each woman develop an individualized plan that aligns with her disease activity, treatment needs, and personal preferences while keeping both mother and baby healthy. The final major hormonal transition I would like to discuss is menopause. Menopause is officially defined as 12 consecutive months without a menstrual period and marks the end of ovarian and estrogen production. While every woman experiences menopause, women with MS often face an additional challenge. Many symptoms of menopause overlap with symptoms of MS. In fact, one of the most common questions I hear in clinic is this my MS getting worse or is it menopause? Unfortunately, the answer is often not straightforward. The menopausal transition, also known as premenopause, typically begins several years before the final menstrual period. During this time, hormone levels fluctuate significantly, and these fluctuations can affect sleep, mood, energy, cognition, body temperature regulation, and overall well being. Many of these changes can closely resemble symptoms that women already experience with MS. As a result, many women feel as though their MS is suddenly worsening, when in reality, menopause may be contributing or to what we are experiencing. Beyond symptoms, there's growing interest in how menopause may influence the biology of MS itself. Estrogen affects both the immune and nervous system and may have some anti-inflammatory and neuroprotective properties. As estrogen level declines after menopause, researchers have questioned whether this loss of hormonal protection contributes to disability progression. Some studies suggest that women may experience faster disability accumulation after menopause, although it can be difficult to separate these effects from aging and longer disease duration. This is important because menopause, aging, and MS often occur at the same time. When a woman notices changes in walking, cognition, energy, or physical function in her 50s or 60s, there are often multiple factors contributing at the same time. It is rarely a single explanation. The encouraging news is that many menopausal symptoms are treatable. Optimizing sleep, maintaining regular exercise, addressing mood symptoms, managing cardiovascular health, and discussing treatment options for bothersome menopausal symptoms can all have a meaningful impact on quality of life. Most importantly, women should not assume that every new symptom represents MS progression. Menopause is a major biological transition that deserves recognition and discussion as a part of comprehensive MS care. One question that frequently comes up is whether hormone replacement therapy, or HRT, is safe for women with MS. While HRT is not a treatment for MS, it can effectively manage menopausal symptoms such as hot flashes, sleep disruptions, and mood changes. Importantly, current evidence does not suggest that HRT worsens MS disease activity. In fact, because as we talked, estrogen has some anti-inflammatory and potentially neuroprotective effect, there has been considerable interest in whether hormone therapy might even provide some neurological benefit. While the data are not yet strong enough to recommend HRT specifically for treating MS, but women with MS should not be denied hormone replacement therapy simply because of their diagnosis. The decision should be individualized and based on the same considerations used in the general population, weighing the potential benefits against the risk and taking into account a woman's age, medical history, and personal preferences. As we conclude, I hope one message stands out. The relationship between women's health and MS is complex, but it is also empowering. The more we understand how hormonal transition interact with MS, the better equipped we are to anticipate challenges, make informed decisions, and provide personalized care throughout every stage of women's life.
Thank you so much, Dr. Mahadri. We now have time for questions. So we have a few that have been submitted already, but if you have a question, feel free to submit it into the Q&A box now. I'll direct the first one to Dr. Williams. If there has been NIDA or no evidence of disease activity or clinical changes, would DMTs be discontinued? And if so, when?
Well, that's a good question. I guess you can ask philosophically, is there anything else to be treated? But in general, when you're starting off with relapsing or remitting MS, if you were to stop treatment sometime after that treatment biologically wore off, you would have some return of disease activity. There are individuals where their MS appears relatively benign. Maybe they don't need to be treated. Or they could be started on a highly effective therapy earlier in their disease, and then doctors might work to de-escalate and observe. And there have been some trials showing that as people get older and the natural history of MS, for them to have fewer relapses in their 60s and 70s, it might be safe for some people to stop therapy or de-escalate, but that we make that on a patient by patient basis. I would say for the average person who's just started treatment, it has been getting great results after having a hard go and before diagnosis, before starting treatment, and they're 35 years old and they're like, I'm great. Say, I would not, stop therapy because of the good results you've had. We are not yet making permanent changes to the disease, the underlying disease.
Thank you. Next question, we'll keep going with you, Dr. Williams, but perhaps Dr. Stark would like to weigh in as well. Where is the field as it relates to the potential for immune reset akin to CAR T for conditions like lupus? And perhaps you could start by giving folks that might not know an overview of what CAR T is.
So the concept of immune reset is not a new concept. People have been trying various approaches to resetting the immune system in MS, including various stem cell transplants, where not repair type stem cells, but a wiping out of the immune system, with a hope and expectation that as the immune system redevelops, you would have eradicated the inappropriate memory B or T cell response. So there have been some successes with these very aggressive forms of therapy, and the question is, are they better than what we're using now? CAR T therapy was developed for cancer, and it's, if you think about, we use monoclonal antibody therapies to treat some of to MS, like Ocrevus or Tysabri, as I mentioned in my talk. CAR T therapy is saying, can we use the other arm of the immune system, the adaptive immune system, take out someone's T cells from their body, replicate them in very large numbers, and program those T cells when we put them back into the person's body on an individual by individual basis. We program those to eliminate a particular cell type in the body. For MS, they would explore B cells and hope to get a more deeper eradication of B cells than what we're achieving already. For lupus, this is looks like it's giving very good results. Take that with a broad optimism. MS is not the same as lupus, so we'll have to see. MS involves autoreactive T cells as well as B cells, whereas lupus is heavily B cell driven. So we don't know what cells we would need to eradicate. It's not as simple, but there will be trials for MS. I believe it's in phase 1. And I do think as there is headway in other autoimmune diseases, it can play into the field's general understanding of how to address autoimmunity so that we may not do the same thing in MS. I don't expect the first trial in MS to work. I expect it's going to be a learning process, but as success happens in other fields, it could play into MS over time. Dr. Stark, do you have anything to add?
Sure. So yeah, I wouldn't really call CAR T resetting the immune system the way that you just explained that the high-dose chemotherapy and stem cells do reset the immune system. It is to try to be more specific in what we're targeting, which has like sort of revolutionized some of the cancer treatments. Leave the good cells alone, affect the bad cells. But as you said, the problem with MS is we don't really know exactly what the bad cells are. And in fact, there are many that have been implicated. And in relapsing remitting, maybe it would be a little bit safer, but we don't see such major issues with our highly efficacious therapies in the B-cell family. The only thing is, again, because we have such much more limited options in progressive MS, and it's possible CAR T could have a direct effect in the central nervous system, we would like to see its role in again, progressive MS. I will say at our center, we have done a lot of spinal fluid research in patients on regular old B cell therapy, and we very rarely see central nervous system B cells, even when you deplete the B cells peripherally. Now, that isn't exactly uh, it's a way to infer that the B cells in the CNS are also being affected by Acrevis. And so potentially there could be an effect there, but it's started phase 2 trials, and it's really early to have any kind of other opinion.
Thank you. We have another question. I'll toss it out there for any of the three of you. Are there any oral medications as effective as Tysabri for relapsing remitting MS? If not, can you say why not? And do you think one day there will be?
I can take that. No, right now there are no oral. You're not really supposed to compare drugs unless you're in it's the same trial with the same patients, with the same duration, with all the same parameters. But in my opinion, no, there are no oral pills that are as effective for the more people in relapse remitting. As Dr. Williams said, some patients do very well with oral medications, and it is 100% effective, and in those patients, that's great. But when you're looking at the whole population of MS, I don't believe they're as effective. The reason why is they have completely different mechanisms of action. So it's not just a matter of dosage or anything like that. And I do think there are levels within the oral drugs of varying levels of efficacy. Do I think that there could be one in the future? Sure. There are. I assume that there are ways that 10 years from now we'll learn more and can try to engineer something that can be absorbed. The problem with oral medications is they have to be absorbed through the stomach or intestines or something like that. And the drugs that are IV right now will never be oral because they are too large to actually be absorbed. Whereas small molecules like BTK inhibitors and something like Tecfidera or the S1P drugs can be absorbed. So that's the major issue with that, which is also why Dr. Mahadri was saying that even if you do excrete some of the medication in breast milk, the baby's stomach just breaks it up and can't possibly absorb it.
Thank you. Another one, if someone is 30 years into the disease, for example, or if they already have a lot of damage, say they're in a wheelchair or another mobility device, how can I think I'm reading this correctly, how can they be prepared for when there is a chance of repair? Is there anything that they can do to help their body be in a good place to receive potentially repairing therapeutics in the future?
I can answer that. Take care of your physical and emotional health. It takes a radical equanimity to be able to say, here I am. if there's an opportunity for repair, we don't know what we're going to need to do biologically, but part of it is being able to have your body be in a good place when you get there. So that holding the idea of one tomorrow or hopefully next year I'll be able to be repaired, hold that idea gently, but also take good care, be a good steward of your body as it is. Look for small opportunities, look for things that are fun, stay mentally engaged. I have some people who are in wheelchairs who've it's a I applaud their work, but they've been able to live full lives. That's part of it because you want to be able to get to whatever point may or may not come and be able to say I'm ready for it, as opposed to coming in worn out. But also it works because if you're a steward of your body, you are taking care of the whole systems that will need to be online. That when we are to induce repair, we don't do it arrogantly. We're supporting the body's natural functions so that you actually want to take care of the body's natural functions as they are, as opposed to thinking there's something miraculous that we would put in without needing to take care of the whole ecosystem. So being a steward of your body is also taking care of the ecosystem that we will need to work with when we have more capacity. I hope that makes sense, but that's how I advise people.
That's a great answer. Thank you, Dr. Williams. Have there been any studies on GLP-1s helping MS patients with inflammation? Very trending topic.
Well, Dr. Bates, do you want to talk about it?
I can talk about it a little. So there's a growing body of preclinical evidence that possibly GLP-1 receptor agonists or GLP-1 medications can reduce neuroinflammation in animal models of MS. However, so far there is no randomized controlled trials in MS patients that have been completed to date. There are multiple retrospective studies that are trying to evaluate GLPs in MS patients, but there's no, as I said, there's no clinical trials as of today that has compared GLPs compared to a placebo. In the retrospective studies, all the patients have been on different other kinds of disease modifying therapy. But this is definitely an area of interest, and a lot of research are forming in the area, but our evidence right now is not really enough to implement anything right now. Dr. Stark, you want to complete?
Oh, I was just going to mention that 2 weeks ago, Dr. Bates actually presented at our journal club an article on GLP-1s and multiple sclerosis, and it was interesting. I think there was better testosterone levels and higher vitamin D because those are both affected by adipose tissue. But I will say GLP-1s have been shown to be effective in a lot of different treatments. Sorry, not disorders, because I think that almost any condition can get better if someone can lose 10, 20 pounds. Certainly in MS, you'll be able to walk better, you'll have more energy, but whether or not they have a role in the immune system on the brain and spinal cord is very unclear, although a study is starting currently now recruiting patients for that, although we are not doing that at this time.
Thank you. We are at time, but I have two more in the queue, so I'm just going to go ahead and ask them. Another specific question: has Tish looked at faricimab as a promising treatment?
Oh, I guess I can do that since I did BTKs. There are a number of things in the pipeline, as I mentioned in my talk. Frexalimab is actually one that's in already enrolled all their phase 3 patients, as far as I know, in progressive and relapsing MS. That is an anti-CD40 ligand drug. This one is much, much earlier in development. I believe it has only done phase 1, and it's an anti-CD3 monoclonal antibody. These are all different parts of the immune system. CD3 is not something that we have really looked at all that much in MS in general, and as far as I know, not in our lab. But we are certainly eager to learn more about it as these trials are completed.
Thank you. In general, is there a medication that you would say is less taxing on a patient's immune system while still being highly effective? I guess the root of this question that they're asking is, how do you decide which drug to put your patients
on? We have to look at the whole state of the patient. The risk of infections or side effects is higher if someone's very disabled, although they may be more willing to accept those risks. Tysabri, if someone doesn't carry the JC virus, or is called JC antibody negative, Tysabri is less immune suppressive for the system. If we're talking about relapsing remitting MS, there are ways we can mitigate the risks of immune suppression when someone is on a B cell therapy. For example, if they had low immunoglobulins, that can be replaced with intermittent doses of IVIG. But we also look at what needs to be done to prevent infections outside of what immune therapy they're on. So there isn't one simple answer I can give for how to reduce that, but certainly, let's say, yes, one of the lower efficacy drugs, I wouldn't, such as Copaxone would have a low risk of infections or be less immunosuppressive, or perhaps one of the fumarates, such as Tecfidera or Vumerity.
Thank
So
you.
we make it's individualized.
Yeah, and I said two more, but I'm going to ask one more just because I think we can. As mentioned a few times in today's session, the majority of existing and new treatments are specifically for RRMS. Is there a specific reason for the dearth of drugs and/or drug trials that address SPMS? And I started typing out this answer just because I like to pitch our research center a little bit, just noting that for a long time we didn't have a disease model to study SPMS specifically. It is a unique disease, and it has distinct mechanisms of disease progression from relapsing remitting MS. So scientists had to perform like less specific experiments because they didn't have that perfect model. And our center was actually able to create an animal model that is specific to SPMS. That was a first in the world discovery by the Tisch MS Center. So we're now able to perform more specific experiments, and that's something that we're really excited to work on and find those unique mechanisms of action. Do you all have anything to add to that, or can you speak to it from a neurologist perspective, Dr. Stark?
That was an excellent answer. I have a more cynical answer. And that is, these drugs all do come from big pharmaceutical companies. And certainly relapsing remitting is the most common form of multiple sclerosis. So if they're trying to make money, that's where they're going to go first. Right now, the relapsing remitting market is so saturated with drugs that we don't really need too many new ones. And that's why the research is going towards progressive forms of MS. It's also just a lot harder, unfortunately. Like the studies would need to go on longer. And you can do a 2-year study in relapsing remitting MS and show MRI endpoints, and in a progressive form of MS, the slowing is just slower. So that would take a longer study, and in that study, it would be a placebo-controlled study, and the patients that were getting worse would drop out, and it would just be logistically more difficult to do. But that is where a lot of the current research is going into primary progressive and secondary progressive MS.
Thank you
And
so
to add
much.
to that,
Thanks, everyone. Oh, I'm sorry, William. Go ahead.
and just to add to that, we also don't see what we need to do. And this is why the new animal model is so important. Is we look at MRIs as if they're showing all the inflammation. If they're not, we need a better marker to know what target, what to reduce, and who's having that inflammation. So that what we're calling PIRA, one day we may actually be able to show it with a marker, blood test, or spinal fluid test, and say this marker, like MRIs revolutionized relapsing remitting MS care. As we develop markers, that's a source of hope. as we see that progressive MS is not the same thing as relapsing remitting MS, they have some overlap, and we might find better immune therapies or better immune understanding that would lead to better immune therapies. That's where the hope is going to come from. But we need to see better or have a better understanding of the biology. So that's why we don't have more trials. But that in time, I expect we will look back at where we are now, the way that we look back at where we were 20 years ago. Like, we just didn't see what we didn't see. And thank goodness someone was creative and pushed forward.
Thank you. Mark your calendars, especially if you like Q&A sessions like this. On August 12th, that's a Wednesday, we'll have Dr. Saud Sadiq, who you all heard their name quite frequently in our introductions today. He is the Chief Research Scientist, Director of the Tisch MS Research Lab, as well as the founder of IMSMP. We'll have a Q&A session with him on August 12th. And on November 12th, which is a Thursday, we'll be speaking with Dr. Jamie Wong. She is the researcher that discovered the animal model I just mentioned for PPMS. She'll share the results of her latest experiments on cerebellar dysfunction and update us on her PPMS work as well. You can also connect with us on social media at TISHMS, TISCHMS, and at IMSMP.NYC. Thank you so much for all of your questions and for joining us this afternoon. We really love sharing MS science and education with you. We'll be sure to send a recording link of this out tomorrow, and it will be up on our YouTube channel as well, along with any previous Quarterly Connect webinars for you to take a look at and share with a friend or family member. Thank you so much and have a great afternoon.